What's going on, guys? Dr. Andrew Fix back here for another episode on the code. Standing inside the treatment room today here in our Denver Tech Center clinic location. Haven't done one here in a while. Thank you for tuning in and joining us, however you're listening to this podcast. Really appreciate you spending your time with us. And by with us, I mean, we are joined again today by Dr. Nate Henry. He's one of our providers here at Physio Room. He's been with our team for over a year, slowly closing in on a year and a half now. And he actually joined us in the past. Nate was on episode number 71 of this podcast, where we talked about all things dry needling related and went into a real big background of Nate's extensive education and knowledge, which is why we love having him on here, love having him on our team. So Nate, thanks so much for joining me again this afternoon, man. Appreciate your time.
Hey man, this is fun for me, so I'm looking forward to it also.
Awesome. Well, what we're going to get into today, you guys, the topic of spinal manipulations, or, sometimes I don't like to use this word, but cracking the back, right? Sometimes clients just come in and they ask us, Andrew, can you crack my back today? And what they mean is, can you manipulate my spine? And Nate happens to be an expert in spinal manipulations, and he actually teaches continuing education courses on this very topic all across the country to all different types of physical therapists and other types of providers. So, Nate, can you do a little bit more of a introduction and brief background on yourself and how did you get into teaching spinal manipulation courses?
Yeah, sure. We talked a little bit about my education at the last episode, but I graduated from the Army Baylor Physical Therapy program in 2010. And as a provider coming out of Army Baylor, you're expected to go to an Army unit, usually consisting of somewhere between 3,000 and 4,000 soldiers, and you're going to be the sole musculoskeletal provider for them. So during school, they spent a lot of time teaching us manual therapy, and that included manipulations. In fact, some of the studies, the premier studies that you see on manipulation come out of that program. And so they taught us how to manipulate and mobilize pretty much every joint in the body. We learned, of course, spinal manipulation as well. I do remember that once it got time to address the upper cervical spine, they pretty much shied away from teaching us that, and cited some concerns with safety for that area of the spine. After I graduated, I went into the Army, treated a whole bunch of soldiers and soldiers' families with the modalities that I learned in physical therapy school, to include spinal manipulation. But all during that practice, I did kind of shy away from treating the upper cervical spine. 6 years later, 2016, I went through fellowship training, manual therapy fellowship training. And there, where we looked at the actual evidence, all of the randomized control trials, many, these are good ones, cadaver studies, like what kind of forces are being put through the spine when you manipulate it. Come to find out, if screened correctly and applied correctly, it's actually a very safe thing to do. And so I learned how to apply those techniques, and after doing that for a while, I got tapped to start teaching other people how to do it. And so I've been teaching others how to do it since 2017, and it ranges from all types of practitioners. On our courses, we'll have mostly physical therapists, but we'll get some chiropractors on our courses. We will have osteopathic docs. They learn a little bit of manipulation in school, and then they don't really seem to apply it much in practice. So after they get out of school, they're like, I want to hone these skills. They'll come and see us. I've had PAs on the course, occupational therapists, even had some acupuncturists, and at one point I had a veterinarian on the course.
Wow, so, amazing.
Those are the practitioners that we teach, and I'll teach upwards of 50 to 100 practitioners a year. How to manipulate every level of the spine.
Yeah, awesome. Well, and I kind of like that we're, diving right into it. And I think one of the key things that you said was, though you went to a program for schooling that did do a lot of teaching of manipulations and mobilizations, a lot of your education of like really diving into the research, really honing your skills and really getting good at it, especially good enough to teach other people. A lot of that happened after school. And that was my experience too, right? I graduated from physical therapy program in 2015, and we learned some techniques. Our orthopedics class provider, he maintained kind of like a private practice of his own where he would treat clients kind of in this cash pay scenario, similar to the way that we operate on the side while he was one of our instructors in school. Yeah. And what I remember was we sort of went through techniques of how to manipulate the lumbar spine and the thoracic spine, maybe the ankle, for example. But when it came to the cervical spine, we didn't do that in class, right? Because our class had like 50 people in it, so they didn't want to do that in lab. He pretty much said, hey, I'll have office hours set aside specifically for like small groups to come in. If 3 or 4 or 5 of you guys want to come in at one time where we can go over the cervical spine, we'll do that. And I think, like you alluded to, a lot of that was because of, the belief that I think is out there of that manipulating or cracking the neck is dangerous, right? And you started to talk about what some of the research says. So, maybe as far as like an overarching theme, like what does the research say in terms of safety of doing manipulations? And then maybe we'll go down the rabbit hole of getting into the conversation of, what's the difference between a spinal manipulation compared to a chiropractic adjustment or something else? But what does it say about safety as far as manipulations go for low back, for the mid back, the neck, in the research?
Yeah. Well, if we want to dive into specific articles, we might be better off, talking offline, because they get very specific, and so it just depends on what aspect of it you're concerned about. Mm-hmm. As far as global recommendations or global things to understand, complications from spinal manipulation are actually quite rare. Some research cites 1 in 50,000, and those are for some minor complications. For major complications, we're talking like, causing a fracture or causing a disc herniation or causing a vertebral arterial dissection. Those are kind of, catastrophic things, and are reported somewhere between 1 in 4 million and 1 in 6 million. So the substantially low risk. Comparatively, if we look at something like, I don't know, ibuprofen, how many people are on ibuprofen? How many of our patients are on ibuprofen, have been for weeks or months at a time? And complications from ibuprofen range anywhere from 1 in 20,000 to 1 in 40,000. So, and that's including, gastrointestinal distress all the way up to and including death. So the complications from, and I don't mean to say, overstate the danger of ibuprofen or understate the danger of manipulation, but they're really not in the same category. Really, complications from ibuprofen are at least, 3 times as many as from the minor complications that come from spinal manipulation. So all of that to say, it's a pretty safe thing to do. Mm-hmm. Now, we want to screen appropriately for our patients, and the primary things that we want to screen for are their vital signs, their history of trauma, and any signs of stroke. As we learn in school, those are the 5 Ds, 3 Ns, and 1A, right? You remember that acronym? Yeah. And so if we can screen for those 3 things, most people are going to be safe for manipulation at that point.
Yeah, I love it. And so now that we talked about what the unlikely scenario that a negative traumatic event like that happens, since we're talking about a podcast here on manipulation, before we start talking about like the differences of this and that versus an adjustment, like we do it in the clinic, right? At least in a clinic like ours at Physio Room, all of our providers are doing manipulations with their clients, most likely on a daily basis, unless they've screened them and they determine they're not a good candidate for it. What are the benefits of doing spinal manipulation? Why would we even do it in the first place? Because a lot of providers take these Con Ed courses that you teach A lot of providers do it with their clients. A lot of clients seek out someone that can do it. Why? What can we expect are some of the benefits of doing it in the first place?
I mean, the benefits are quite a few, but I like to distill it down to three basic things. So number one, when we manipulate someone's joint, be it the spine or an extremity, we're looking for an improvement in range of motion. So typically when we think of improvement, we think an increase. Hey, we're going to increase the range of motion. And in some cases, that's true. Somebody that doesn't move too well, we can get them moving further or farther. But that's not, when we say improvement of range of motion, there's a second part to that. And that is the quality of movement. So let's say we ask somebody to bend over and touch their toes. Someone might move towards touching their toes quite smoothly and they can touch them right away. Well, maybe that person doesn't need a manipulation, but you might have someone else who they can do it. They can bend over and they can touch their toes, but man, it looks nasty getting there. It's like they don't move that well.
Yeah.
And so when we talk about improving range of motion, we can increase it, but also we want to consider, hey, that we may just be improving the quality of the movement.
Right.
And again, that's not just for the spine, that's for any joint. So that's number one, we're going to improve range of motion. Number two is there is a connection between how a joint moves and how the musculature associated with that joint operates. And we can get into details about stiff muscles or muscles that have trigger points in them. But really what it comes down to is when we manipulate the joint that's associated with that muscle, we can get that overactive muscle to calm down. And this has been demonstrated in studies, including electromyographic studies, where they measure the electrical impulses in the muscle and see them calm down with the use of spinal manipulation. And then lastly, we can affect the central nervous system as well. And the explanation on that can be a little bit complicated. More than happy to discuss it. It just might bore some people, but suffice it to say, our spine, our nervous system gets very good at doing what it repetitively does. And that includes feeling pain. So if we have something causing pain, and that happens for several days or weeks or months in a row, our spinal cord learns how to relay those pain signals really well.
Yeah.
And when we manipulate the spine, when we manipulate the peripheral joints as well, it gives input to the spinal cord and eventually to the cortex that says, hey, all of these neurons that are like turned on to relay pain, it tells them to calm down. Now, all of these benefits can happen with one manipulation. It does tend to be cumulative, and most studies that measure how many treatments are required to have an effect, most studies, it lands somewhere between 6 and 12 treatments, so now I've had plenty of patients that's like one and done. Hey, we do this one time and they're good for a long time. Most people are more like 6, 7, maybe 10 manipulations before that happens. We also find, the last thing I'll say, and we can talk about this a little bit more, is in general, it should be part of a plan of care, not the only thing in the plan of care. It tends to be complementary with multiple other parts of a plan of care, specifically exercise, which is one thing that we're absolutely expert at Physio.
Yeah. So on that train of thought, being a component of the plan of care, we operate under this 3-step process principle called reset, restore, reload here at Physio Room. Spinal manipulation would fall nicely under that category of a reset.
Absolutely.
Yeah.
And it can be used in the restore phase also. It can be used in the reload phase also, but it is terrific for the reset phase, where we're trying to give some input to the nervous system, calm down the muscles, and getting the joints moving a little bit better.
Yeah. I like that explanation of your spinal cord, your other nervous system tracts get really good at what they do a lot of. And if we're sending so many pain signals over and over and over, they get really good. Your body gets really good at feeling that pain. And we can break that cycle a little bit, break that effect with the input we're giving through something like this. So Nate, how does that work from like a downflow effect the other way, where like if we manipulate somebody's back, for example, in the clinic, and say this is let's use the client example of a high school female cross country runner who has knee pain. She doesn't have back pain, right? She has knee pain. And she's coming into the clinic, and we determine, hey, if we could just get your hip functioning better, we likely can improve your knee pain. If we can get the muscles around your hip controlling your gait, controlling your movement better, we could likely improve your knee pain. What would the potential benefit of doing a spinal manipulation in somebody like that be, where those nerves that innervate those muscles come from the lower back in the SI area? Why might we manipulate that person?
Well, I mean, that's a classic example, actually.
Yeah.
Someone with some knee pain or lower extremity pain, and really all three things that we mentioned that manipulation does might be involved with that. So the knee joint, anytime we get pain in the knee joint, we should absolutely look above and below, because the knee joint it's just a bridge between the multi-directional articulating hip and the multi-directional articulating ankle, whereas the knee is, it's pretty much a hinge joint and a tiny bit of rotation to it, but it's just a translation. So as soon as we see that knee pain, let's look up at the hip, as you mentioned, and you can't look at the hips without looking at the spine, man. So all three things are going to be at play there. If we manipulate their lower back, we're going to improve their range of motion. And actually, we should probably involve some manipulation of their femoral acetabular joint, their hip joint as well.
Yeah.
And get those both. And we might even consider the sacroiliac joint, the SI joint. One thing that I meant to mention is that when we manipulate somebody, one thing that we are not doing is, quote unquote, putting their joints back in place. Joints at most will move about 2 millimeters, right?
Mm-hmm.
When we manipulate them. That includes the spine or the knee or the hip, wherever we're going to do the manipulation. So now it absolutely feels like it's in a better spot. It feels like it's back in place, right? And that's when we manipulate the spine or manipulate the hip, that's how that athlete, that high school runner, is going to feel. They're going to feel like, wow, this feels like I can move a little bit better, maybe even a lot better,
Yeah.
And then we've calmed down the musculature in the lumbar spine as well as around the hip. I mean, how much are the hip flexors and the gluteal muscles involved with running? It's quite a bit.
Mm-hmm.
And if that athlete's been dealing with this injury for a long time, we're absolutely giving input to the central nervous system to say, hey, you don't need to be relaying this pain quite so much.
Yeah.
I would say in that scenario, that's again, classic example. All three things are at play with that.
Yeah. Yeah, I like that. And since you brought up that topic on, we're not putting things back in place, right? We're creating a stimulus to that joint, to the nerves, providing the body with some input. What is the difference between, what in a chiropractic office might be called an adjustment, compared to in our office is typically called a spinal manipulation or some other joint manipulation?
Yeah. Well, that's where we're probably going to get into some semantics of what the word manipulation means.
Mm-hmm.
And what I think the best way to define manipulation is what makes it different than other things, because we have joint mobilization, and what that means as a therapist, and some of our patients might know what that means. That means, hey, we're going to put hands on this joint, we're going to move it back and forth nice and slow 30 times, and then we're going to rest, and then we're going to do it again. We're going to do that 2 or 3 or 4 times. That's going to be a mobilization of the joint. A manipulation is going to be different than that. And probably the 3 criteria for manipulation is, number one, it's going to be very fast. And it needs to be faster than human reaction time. Human reaction time is about 0.2 seconds, so it's got to be faster than that. Number two, there needs to be a decent amount of force. We don't like to use, we don't want to force joints to do things, but as in terms of force, you've got the speed and a little bit of force going through.
Mm-hmm.
And then number three, and there's quite a bit of debate about this, but there needs to be a cavitation, a pop, and that's going to make some practitioners really mad. They're going to want to duke it out with me, but there's some decent evidence to show that the cavitation is important, and that there is a difference for the patient when they hear that audible pop, no matter which joint it's in.
Yeah.
So those three things are probably what define best a manipulation. The fourth thing that I would add to that is that in terms of what we do, what we teach at Physio Room, how we operate at Physio Room, we do all of our manipulations in mid-range. We don't take joints to end range and then past that.
Right.
Call that paraphysiological range. We don't want to go past normal physiological range. And so that might be a difference than what you may see from other practitioners. And as far as defining the difference between manipulation and adjustment, I mean, that could be a debate for a long time,
Yeah, totally.
What it comes down to for manipulation for me, and I'm speaking for me in the research that I've done, is the time, the force, and the audible pop, the cavitation. And then maybe lastly, it's probably best and safest to stay in that mid-range.
Yeah. Yeah. What do you think about this, Nate? And part of my question comes from, I was actually working with a client yesterday here in our office, and we got on this topic because this particular individual has lower back pain. She also has neck pain and several other things that are going on, but specific to her neck pain, I was doing a manipulation for what we call our CT junction, or cervical thoracic junction. And this person has had chiropractic care in the past. And what I'm about to say is unique to this individual. This is not a generalization that I'm making, so please nobody misunderstand me. She had a poor experience in that setting, right? Yeah. She had her low back adjusted more forcefully than she was expecting at the time. And she left that appointment with more back pain than she went in with. And it continued to be that way. So she told me on her first visit in here, I had my back cracked before. I don't think I want to do that. I didn't have a good experience. So we were having a discussion about what you just said, how, hey, we're going to do what I would like to do is this mid-range manipulation to try and affect these joints. This is how we're going to do it. We're not going to be taking you to an end range position. That calmed down her nerves a lot as it relates to what we were about to do. We did a cervical thoracic manipulation. She had a very audible, without very, very much force needing to be applied for me, a very audible pop. She felt some sense of relief afterwards. She had improved range of motion, like what you just said. But one of the things I told her in our explanation of like, well, what is different between an adjustment compared to a manipulation, what we're going to do is I talked about this idea that I am not trying to work on a single specific joint. I am not trying to work on a single specific spinal segment or this facet joint. I'm working on this area, right? This is a general manipulation for this section. This isn't for like the L5 on L4 right-sided facet joint. And that's an explanation that I give clients a lot of times, that like that, hey, this isn't a very, very specific spot. This is a general thing for your lower lumbar spine, for your upper lumbar spine, for your thoracic spine that we're trying to accomplish. Have you found yourself in that conversation before?
Oh, sure. Yeah. And this is up for debate amongst, fellowship trained manual therapists throughout the world. They talk about, you'll have some that are very much about the very specific one part, one place, one pop kind of approach. The problem, and part of the problem of that is this. I mean, these studies have been done where they mount microphones all along the spine and then
Mm,
manipulate, and then they'll interview the practitioner. Hey, where did that sound come from? They'll interview the patient. Hey, where did that sound come from? And they'll ask the practitioner, what area were you targeting, right? And when they actually look at the microphones and where the sound came from, it's anywhere from 1 to 5 segments away from where the practitioner thought it was, from where the patient thought it was, from where the
mm,
practitioner was targeting. And so, what we think is happening may not be what is happening. And so, for that reason, primarily when I go to perform a manipulation on somebody, I'm going to try to do as much of a global type of treatment as
yeah.
I can.
Yeah.
And so let's say it is the lumbar spine, as you mentioned. Let's say it's L3. I'm going to try to target like, T12 through S1 and get as much of the lumbar spine as I can.
Yep.
And hopefully, and I know it's not a very scientific word to say hopefully, but hopefully address that area that is of concern for the patient.
Hmm.
And so that's kind of how I'd answer that. I was taught early on to target very specific areas, but I've learned as time has gone on that that you can't really do that. It's very
Yeah.
difficult to do that and be accurate.
Yeah.
Um, and then the other thing that I'll say, and as I've said, I've trained practitioners all around the country, and you've got some therapists that are great manipulators, and you've got some others that unfortunately just aren't very. They need some more training, shall we
Yeah.
say?
Sure.
And you have the same thing in the chiropractic community and in the osteopathic doc community and the PAs and our nurse practitioners also that do this type of modality. You're
Yeah.
going to have those that are very good practitioners and those that need just a little bit more work.
Sure.
Um, and so, stay humble and chase perfection, but be okay with being, pretty good. And that's what we're trying to do at Physio Room. We try to train everybody up. And I like where we're at. I've worked with each of our practitioners and been impressed with how, first of all, how hard they work, and second of all, their skills. And I am comfortable with each of them manipulating my spine, for instance.
Yeah.
Yeah.
Yeah. I would say the same thing. I don't have any hesitancy. If I were to be in the room with any one of our providers, I'd let them go to town. So, but I think you're totally right that, and to me, it's not just a number of reps thing. Like, yes, the more reps I've gotten, the better I feel like I am, the more confident and successful I feel like I am at doing manipulations, doing dry needling, whatever that might be. But it's really those like intentional reps, right? I mean, if you're just screwing around and you're doing something, but you're not really being very intentional and purposeful of what you're doing, and you're just hanging around with friends and cracking each other's back, that's not the same as like really trying to dial it in and set up the scenario so that, and what I found is the setup makes such a big difference, right?
Oh,
How do you position the person? And there's so many different ways that you could go about manipulating a certain area, which is what I find. Speaking of like chiropractic offices, for example, well, I could probably refer a client to 5 different chiropractic offices, but that provider might provide a different adjustment based on their skills and their training. And I think, what we learn and what you probably learn when you're having students in courses is, or providers in courses, is maybe their background of what they've learned before, or the techniques that they've learned before, are different from person to person or region to region. I mean, heck, even some states, I still don't think even allow manipulations by certain providers and whatnot. So yeah, it's just a little bit different. And I find that, like you said, the more we practice it, we get those intentional reps, we get better at it, and our skills change.
I agree. That's one of the reasons that we try to do the in services. We don't try, we do. We do
Yeah,
the
right.
in services at Physio Room and train each other up very intentionally.
Yeah. Okay, another question for you. How about like from a downflow effect in terms of, does doing a manipulation, say the spine, for example, Does that provide any like downflow signaling effect to assist with getting muscle activation and getting recruitment of muscles, right? So like, how does that process work? And is it the same or different from the, breaking the pain signal or getting the guarded up, tense muscles around a joint to relax from doing a manipulation compared to, hey, we're trying to get them to be more active so that now we can go do exercise and strengthen them?
Yeah, for sure. We have enough studies out there to show that muscle recruitment following manipulation is improved. Um, and it is a very similar kind of mechanism or pathway as getting taut muscles to calm down. So as far as, downway effects, spinal manipulation can be a great thing to get people ready for activity. As far as like elite athletic performance, I'd have to say that's more of a kind of on a case by case basis. And that's where, our athletes that we see at Physio Room, it may take us a couple of visits to determine how that person responds to manipulation.
Yeah,
Some athletes, they might be too loosey goosey afterwards, and
sure.
so it's not necessarily worth the extra muscle recruitment that they would obtain if we're making their joints feel all too wobbly. For other athletes, it's a terrific way to prime them up for their performance. So that's something where I hesitate a little bit if somebody comes in and just says, "Hey, I need manipulation, get ready for my race tomorrow," or whatever. I'm going to want to be able to dig a little bit deeper on that,
Yeah, and actually, since you laid out that scenario, what's like the time frame for some of these effects? And this is sort of a two-part question, two totally different questions, but so that I don't forget. What if we have somebody that is very stiff compared to somebody that is very mobile, right? And how, what's manipulation like with those? And it's kind of interesting that we're having this discussion today because yesterday I recorded a podcast on that topic, being lacking range of motion compared to having way too much range of motion. But so what about that difference? And then how long do some of these effects last for? So like say I have an athletic performance that I want to do and I potentially wanted a spinal manipulation, like what sort of time frame are we talking about that's actually going to be able to help me?
Yeah. Well, first of all, I'll answer your question of how long do we expect these effects to last? So, in general, and it varies from person to person, but in general, I'm expecting the effects from manipulation, my first one, to last for about a day. Some people it lasts longer, some people it lasts less. That's why I like to follow up with my patients the next day to see how they're feeling, because we want to see what kind of effect that we had. It does tend to be cumulative. So as we add more and more of these treatments, and that's where we get, more like to 6 to 10 or 6 to 12 treatments, then those changes tend to be sustained. And we sustain them for days and then weeks and then months, right? That's in general. Now, for somebody that is wanting it for athletic performance, again, I'm speaking in generalities. I just got through telling you that it varies case to case, but
Totally.
in general, most athletes, the day prior is probably pretty good. And then those effects, last for about a day. And now, again, somebody that's been treated over a long period of time, it's probably going to last longer and they'll feel those effects longer. But in general, athletes day before is my, professional experience. And if you have something different, that I'm totally open to hearing about that.
No, I like that because, a lot of times we're not seeing somebody in the office the day after we just saw them. We're, like you said, we're following up with them. But typically, like in a treatment session, how I try to explain that to clients typically is, hey, we're going to manipulate your back or we're going to manipulate your hip, or I do typically the manual work, right? That type of stuff, or dry needling or something else, typically prior to heading out in the gym or heading out in the clinic and doing more of the restore, reloading, movement, range of motion, strengthening type of activities. And that's one of my reasons for doing that. One, hopefully we've improved the quality and the feel of their movement, but two, if there's some down signaling positive benefits on muscle recruitment, well, I want to take advantage of that. So let's not manipulate them 5 minutes before they walk out the door. Let's do it early on in the session so that we see those benefits in our treatment session. That's mainly how I tend to think about it. But as an athlete too, yeah, that was just a curious question I had. How long does it last?
Well, and when I say the day before, I'm probably thinking, hey, they're performing, they're going for a race,
Right.
when they're in training, the day of is probably fine,
Yeah.
and then just kind of see how they feel.
Yeah,
And
makes sense.
you asked about a hypermobile person versus a hypomobile person.
Yeah.
Um, should we manipulate that person that is stiffer versus that person that already maybe has too much range? They're double jointed or whatever you want to call it. Recall that the first thing that we talked about that manipulation does is that it improves range of motion. So that can mean that we increase range of motion. So for that person that doesn't move very far, or they're hypomobile, yeah, we should manipulate them to increase their range of motion.
Mm-hmm.
But for that person that's already kind of, again, double jointed, loosey goosey, can we manipulate that individual? And we may still want to, depending on what their quality of movement is like. So if their quality of movement is poor, even though they move plenty far, we might consider manipulation so that kind of it smooths them out, right?
Yeah.
Helps them a little bit better.
Yeah. Yeah, that makes sense. And I think in that scenario, what we're oftentimes talking to the client about is the need for stability, the need for more motor control, and manipulation can help us obtain that, help us with that motor recruitment to get more of that control, yes, which might help their movement have a better quality. So no, I like that. I feel like we're missing something, Nate. What else are we missing on the topic of manipulation? I mean, I feel like it is becoming more and more common in our profession that you could go to a number of different offices and at least somebody there is going to be somewhat skilled in this skill set in the manual therapy side of things. But I know it's not 100% by any means that you couldn't walk into any physical therapy clinic and every provider in the door is going to feel very confident about manipulations and use them when they're clinically appropriate all of the time. So I do think from a client or a patient perspective, because I think that's more so who's listening to this show, potential clients or current clients as opposed to therapists. But you got to find the right person, you got to find the right provider, just like anything else. Find the one that fits with you and your goals, and has an understanding of the sports or activities or things that you like to do. Because not everybody's going to have the exact same skill set, unfortunately. Or fortunately. Yeah, it's not an unfortunate thing. Yeah.
Yeah. Hopefully, if you've gone through physical therapy school, you've been exposed to at least some sort of manipulation.
Yeah.
But I have not seen, and like I said, we got exposed to it a lot in school. And there were many parts of manipulation that I felt pretty confident in when I left school. But if you're looking for an expert, it's going to have to be someone that has done some more education since school. That's just totally. That's how it's going to have to be. It would be. I don't think I've met someone that is an expert manual therapist that left school and has just been practicing on their own and hasn't sought some type of additional education or mentorship.
Yeah.
So that's one of the reasons, and I guess we're biased because this is a Physio Room podcast and we're Physio Room practitioners, but that's one of the reasons that we pride ourselves in promoting continued education amongst our staff.
Yeah. I think not that we need to go around beating our own drum or tooting our own horn, but not all physical therapy practices have a podcast. Not all want to have a podcast. Sometimes this is hard to talk about, pushing the profession forward, pushing skills like this. And I think our team is trained up very well. I think they get reps in practice. I literally see the blocks on people's schedules to practice manipulations, or what we sometimes call pop quizzes. in our office. So like I know it's happening because I see them on there, and we schedule time when it fits with each other. Like I have a visit with one of our providers on Thursday of this week to look at stuff that's going on in my body. So we're trying to practice what we preach and continually update and learn. It's not always easy, right? Like it obviously takes time to do these things, but I think every provider got into this to try and help clients. And if you just keep doing the same thing day after day, year after year, man, you fall behind really fast if you're not out there seeking out the new skills and updating things as more and more information comes about.
Absolutely agreed. I mean, we started putting continuing education on our training schedules. We have our quarterly meetings.
Yeah.
We started putting that training on there, and it's hard to fit everything that you need to fit into a
Oof.
quarterly training meeting. And
Yeah.
when you're looking at the schedule and you're like, everything we got to go over, like, this manual therapy training, should we shorten it or should we? And I really like that the leadership team at Physio Room has kind of put the foot down and said, no,
Yeah.
this one, if anything, we're going to increase the time that we're
Yeah.
doing with this, not decrease the time. So
Totally.
yeah, very much appreciate that.
Awesome. Well, yeah, and I think it's been fun since we started hosting continuing education courses in our office now, which brings in a lot more providers that aren't even part of our team, and it brings in a lot more minds and a lot more question and answer time. And I think it's just going to help improve our skills by having those in our office. Just from the purpose of like we're constantly having this conversation. But man, this was fun. Now I feel like I want to go next door here and talk to my team member Edward and say, hey, can you manipulate my neck? But get some of these benefits. But for all you guys that tune in to listen, we're going to wrap this up. But hopefully this conversation maybe brought up some questions for you. Maybe you're a client in our office, maybe you're a client somewhere else, and you're wondering, oh, I wonder why my provider has been manipulating me. What are the benefits? Maybe we haven't talked about that. Or maybe you're wondering why they haven't. Or maybe you have had one type of experience, maybe you've had another. But if some questions come up from this conversation that we had, we would love to know what they are so that we can dive in and potentially answer them for you, whether that's on an individual level and we send some messages back and forth, or whether it's a big overarching question and we record another episode on it to spread that out to everyone else too. So Nate, thank you for joining me, man. Thanks for spreading your knowledge on manipulations. And this was fun.
Hey, yeah, it was fun. If anybody has further questions, let's hop on a phone call. The only problem you're going to have is getting me to shut up. So
yeah, Nate's got a lot of answers, and he and anyone else on our team, if we don't know the answer, we're going to tell you that we don't know, and we're going to help you try to figure it out. So we'll do the same thing on this show. Please let us know what questions you have. And if you've listened to this before, we have a goal. We're trying to get to 200 5-star reviews on this podcast. We just had another one added today. That was awesome. So please go listen, drop some reviews on there and ask us the question that you have. And we'll catch you next time on another episode of The Code. Thanks, guys.